Hi, this is Dr. Carl Goldkamp. If you're interested in learning about the ketogenic diet like I was, to save my own life, then this is probably the podcast for you. 8 years ago, I knew nothing about it. 6 years ago, it saved my life. 3 years ago, I started researching and talking with some of the authorities in the field and attending medical conferences about this to understand why and how keto so dramatically changed my and my wife's Judy's lives. The purpose of this podcast is to share our journey of discoveries with you and understanding how keto is so effective in improving so many different conditions, from obesity, epilepsy, diabetes, infertility, MS, Alzheimer's, heart disease, to name a few. So take a step away from all the hype you've probably heard and roll up your sleeves with me and join me weekly to explore this living miracle that anyone can access. We'll talk science, we'll talk food. We'll explore its history and evolution to today, which is that the sheer wonder of the ketogenic way of eating has changed untold number of lives, unlike anything before it. And in case I forget to mention it, please join our Facebook group, Keto Naturopath. Hi, this is Dr. Carl Goldkamp, and welcome back to another episode of the Keto Naturopath. I thought I'd begin today a series, and it may not be immediately sequential series, on cancer relative to keto. It's a very broad issue, and I don't want to pretend I'm going to set up a simple answer, like just do keto and cancer's fine. I've heard that a lot, and that's in part what motivates me to have this topic, is to go into some of the details and saying, you know, it is a big deal. If anybody wants to do some little research, seek out Tom Siegfried. Certainly go back and listen to the 2 or 3 part episode I did with interviewing him. And then the prequels actually, that I did about his work prior to talking with him. So I think you really need to know the larger context. And what I've learned from patient care of 16 years and in essence, umpteen thousands of patients that I've talked with one-on-one, is that you give a set of instructions, however simple you think they are as a physician, the patient is going to trim it down to what they feel they're willing to do and is the most direct route. And so they may actually totally obliterate some important points that you try to get across. Usually the instructions are not that complicated, by the way. So we're not asking them to run around the house and climb cliffs or, a food prep that is extraordinary or something like that. We're basically laying out a viable way to do life for the next unit of time before we meet again. That's pretty much how a practice goes. This is as a naturopathic doctor. And so with that, you tailor in your advice. Now I'm pretending you are the naturopathic doctor. You are the physician. And you tailor in your advice into whatever other doctors are seeing. So more than likely, they're seeing 2 or 3 other doctors, all what we would say allopaths or MDs. So you probably have somebody who's a rheumatologist giving them certain medications, somebody who might be a cardiologist, somebody who might be they're OBGYN or they're GYN anyway. And so there's a lot that you sort of have to take in on your intake, just on terms of what their life is about right now. Then, of course, you do the environmental intake. Where are they living? How are they living? Then you do the dietary. That is the required. We've gone over this before. I know that is required information. What is you're actually eating? 7-day diet diary. Everything that you eat, please. And then you have the history of their past blood work. So that's the beginning. That's the context. That's me trying to say, all right, I need to know the context of your life before I tell you basic things to do. So that's the antithesis, in essence, of what a person really wants. A person comes to you and wants one simple pill, ideally, that they can take that will correct the issues they have in their life, usually around pain, literally pain points. So can you make them better? Well, for well over a decade, I did a lot of acupuncture and I did a lot of Chinese herbal medicine. And so I really loved that part of the world. It was much more personal. You didn't give people the same sort of set of points. You didn't treat the same points. You didn't do the same point insertion of needles in the same way in various different patients. That's what a learning acupuncturist would do. They would know these technique differences. And when it came down to Chinese herbal medicine, which were mostly plants that had been powdered and dehydrated and already decocted, and then you'd be mixing these together as a formula. That took a lot of time, but it was wonderful that it worked, and usually worked without side effects as you narrow down the stage that the patient was in, as well as who that patient was. So you had to assess them in many ways. And so that is not done in allopathic medicine. It's like, well, here's this med. You go in and you get your blood work done, right? Oh, your cholesterol's high. You need to be on a statin. That's not a very complicated conversation to have, correct? And then not only that, now that most of the population is somewhat educated on the downside of statins, they'll say, well, why is that? Isn't that a problem? Won't there be some problems with the statins that I won't like? I mean, that's about as thick of a conversation that gets, and that's really pretty superficial. You're asking questions on the medication because now statins are pretty much so well known. But take when I had colitis and ulcerated Crohn's and ulcerated colitis, is like, there was no, let's talk about the medication. No, you have to be on this on the rest of your life, kid. Not delivered in quite that sort of tones, but no, this is something you're going to have to be on the rest of your life. And yes, you will have to give yourself shots a couple times a week. And yes, you'll have to be on these 2 or 3 oral medications as well. I'm sorry, but this is the situation you're in. Can you imagine that? That's as far as it goes. And it's like, so if you don't agree with that, who are you going to turn to? Well, ideally, there's some other practitioners in the environment that person's environment that will be able to help them out. But usually the question is, there isn't a backup. Suddenly this person's out in the street by themselves, figuratively speaking, about how do I do this? What is it that I should do? Oh, so why I did that sort of circuitous little background is because everybody's in a different spot. And if we're talking about cancer, there's different kinds of cancers. There's different ages of the people. There's different genders of the people. And so these are things that have to be taken into account. So when we march forward and go, well, my cancer treatment is, when we talk about chemo, that is one treatment for all these people. And if you've ever gone into a chemo room, they're sitting around in chairs and getting their IVs, or sometimes they take it orally at home. There are different people, in different situations, and their causes for the cancer were different causes. Isn't that relevant? Not really in that context. They don't want to go there. It's not what they do. And some people actually do benefit from chemotherapy. So you can't say it's wrong. It's just not many. And it depends on the cancer. And okay, we got that. I hope you are getting this vibe that I'm putting across. So as I'm going to present this idea, this series of podcasts of what would one do if they had cancers. I'm not going to break down all the cancers. It's too big. That would come back on a question. So if you have various cancers, you can ask me those questions and then we'll get specific. But otherwise, that would be a huge list. And we're going to talk about the application of keto. And it's not just keto. It's not like you go to a keto cancer doc. You walk in the door and you go, doc, I have prostate cancer. What do I do? Oh, here's how you do on the ketogenic diet. Boom. No, it's, I don't think anybody would say that, by the way. The context is, well, let me see your labs. Let me see your blood work. Give me your data. What's going on in your life? And maybe, and there's not really much information, by the way, on prostate cancer and keto. It's very vague. It's not as black and white as, let's say, certain brain cancers and certain neurological situations that seem to benefit very, very well and quickly. So each is different. So I'm going to go into what I would do if I were Dr. Carl Goldkamp, who had cancer. And by the way, I just was diagnosed with basal cell carcinoma in the middle of my back. And you go, where'd that come from? Well, we lived 5 years in the Cape just a little while ago. But I have a feeling that it came from a long time ago when I worked for about 3 or 4 years on the equator in Indonesia in the oil field. We were under a lot of sun to the point that I described the sun as shards of glass that just strifed through you on a daily basis. So I think that's where that came from. So that will have to be carved out, as they say, or they don't say carved out. They say there's another word. So that'll have to be taken care of. So we all have cancer in our environment, one type or another. And basal cell carcinoma is the most common type of skin cancer, by the way. It's not melanoma, and it's certainly not squamous, and then you can go on from there. So we're going to talk from this general level going forward, what I would do, and then what I would prescribe in terms of when patients come in, this is what they have to have in place to work with me or to have worked with me. It just has to be that way. It's not on a per conversation basis. Because if you're going to, the problem about being a physician and having a conversation about cancer, there's an implied liability. And that's why every physician has liability insurance. And depending on the nature of your specialty, it could be very expensive or maybe not that expensive at all. As a naturopath, it was $10,000 going on $20,000 a year. It's just ridiculous. Just ridiculous. If you are an oncologist, it's much more expensive. If you are a OB/GYN obstetrician, it's very expensive. So that's one of the big deterrents in going into medicine, is because these added costs that you have to put up with and the very little reimbursement you get from insurance companies. Whereas people think you make a lot of money, at least they did with me. I wasn't that other kind of doctor. So anyway, setting up the structure of how an intelligent person would go in and saying, all right, I'm interested in understanding how keto applies to my situation, and I've been diagnosed with cancer X, be it breast cancer or bone cancer or brain cancer and so on and so forth. You're going to have to do your own research. You know, the doctor, being me, so to say, in that situation, is not going to be your librarian and giving you every new study. That's certainly already been done. I'll pull it out of a folder and have the front desk get a copy for you. That kind of thing. Of course, now everything's online. And so there's a part of, you're going to have to jump in and educate yourself and be part of this. It's a collaboration very clearly. It's not you come in and let the IV nurse give you your chemotherapy for the day and have you nod off. No, we're not going to be doing that. That's not what this is. This is you're participating and I'm participating, and let's take care of this. Okay, we clearly are going to look at diet. So we're going to explain why keto might have a relevance here for your cancer. Maybe cancer in general, but it does not respond to all cancers as we know right now. And there's not a lot of information currently available on various cancers relative to our human cancers and their treatment. So it is basically nothing at all. So when they talk about keto, it's usually something at a very genetic or molecular level that they've discovered in mice or rats or whatever, but it's not in humans. And so the step into human work is pretty much, that risk is pretty much borne by the patient. You know, it's because there's not a lot of documentation. So again, I refer you to the interview I did with Dr. Siegfried, because there was a case that had great outcomes, and then the person did so great, disappeared for a year, came back and didn't do well at all. So there's a lot of variables. We can't pretend that it's straight up, hey, this is what's going to happen. However, let's say if I have no particular plans to change anything with basal cell carcinoma, but if I had a kind of a brain cancer, and we'll leave it at that I would certainly find an oncologist. One that focused in that, any sort of cerebral tumors and so on. And I would take it upon myself by notifying the doctor I was working with that I had planned to do a ketogenic diet. And what does that mean? That means very low carbs and potentially high fats, or not high fats, but very low carbs. And I would track that. So the tools that I would use would certainly be a glucometer. It would also be a CGM. And I would try to convey to this physician that he or she could help me get a prescription to the Freestyle Libre. Or if you wanted to, you could go up to a Dexcom. I think it would be quite relevant. But anyways, if they could help you get the prescription for that, so you can now get your cartridges and go on and start seeing your glucose levels throughout the day. It's such a great education. You need to have that. So this is now a required piece of, in essence, your cancer treatment. Just got to have it. You would also have a ketometer. So we use Keto Mojo, of course, and it's both a ketometer and glucometer. So you can say, wait a minute, it's a little bit of a redundancy for the CGM. It is, but who cares? Better have redundancy than not at all. But the ketones, when you do your ketones and your glucose, you're going to be able to calculate your GKI, which is your glucose ketone index. And your glucose ketone index was something that was basically invented by Dr. Siegfried. And he has a therapeutic range, or used to have a therapeutic range of have that be within 2. Ideally, if you're in cancer, if you really have a pretty serious level of cancer, then you want to narrow that range, which means you're mostly burning ketones. There's always glucose in your blood because parts of your brain and other parts of your body need a little glucose, but you're predominantly a ketone creator and a ketone burner. You're burning fat. And that has to be the way it is. And that would be very important. So let me back up and also say, what is the concept here? Again, I don't want to go into the whole many hours we were talking with Dr. Siegfried, but you are trying to suffocate the cancer in essence. So suffocate speaks to air. I'm using that incorrectly, but it's a great visual. Suffocate the cancer by making sure the preferred fuel for cancer, which is glucose, is hard to get for the cancer. So if we could actually have a switch and turn off all glucose, except for a small little stream for that parts of your brain that need it, that would be great. That would be ideal. And so what would happen is your cancer, this is the theory, it has been borne out in enough situations, but then, they're not doing this in the United States. They're doing it in Turkey and Egypt and Hungary. Hungary's really has a nice center for this. We're doing this. So it's not here. It's basically, due to politics, due to a lot of things, it's just not being done here. Okay, so now you're setting yourself up through the ketogenic diet, dropping the carbs. I would say feel free to go to almost no carbs. I don't do carbs, but I do a pretty high protein. And let me talk about protein. So protein, you can't just, if you have cancer, you can't do what I'm doing, given what we know so far. Because cancer slowly can convert into glucose, called gluconeogenesis. However, it doesn't do it as conveniently, as quickly, or as efficiently as glucose does, or as carbohydrates do. Carbohydrates get broken down directly into glucose and another kind of monosaccharide. That could be maltose, could be galactose, you name it, okay? But there's glucose in there, and so glucose is very quickly, one step, and it's off to your bloodstream to feed whoever that needs the glucose. Okay, so you're trying to really reduce the ability of your body to have access to glucose, right? So the only thing you can control is what you eat, and that is exogenous glucose. So that you can control. If you didn't eat another carb for the next 30 or 40 days or years, well, you could still get by because your protein and your body, and even some of your fats, by the way, will be converted. It can break things down and get then, it's kind of like a chop shop. All the pieces get broken down and can be reassembled into glucose. It's a much slower process, as you can possibly guess, but it does happen that way. So same as is true with epilepsy. They would reduce the amount of protein with pediatric epileptics because they didn't want the end product of glucose to be available to those nerve cells. That seemed to be the thing that was setting them off. So too is that the case with cancer. It's the cancer cells who are saying, can we not do this? Can we not have glucose available? So there's that. So that's the cut and dry picture. Cut off the glucose as much as possible. Have high fats, where now the fat obviously is the precursors, if you will. That's the substance. That's the fuel for creating ketones, and then your body using ketones to fuel yourself. And then the protein, of course, you need that for the structure and enzymes and so on and so forth, but you just can't have too much protein. So in order to get started with cancer, this is not for everybody. The door you have to go through is really a brief fast, ideally a 3-day fast, a 3-day water fast. And you could have things like coffee or tea and so on and so forth. But ideally, if you can just do 3 days of drinking as much water as you want, your body is going to go kind of cold turkey. You're cutting off your glucose, obviously, your exogenous glucose, and you're now totally dependent on your body making whatever glucose it needs by breaking down the fat you have, right? That's pretty straightforward. You're going to get ketones is going to quickly become the preferred fuel, but you're also going to get some glucose there too. But you have to go through cold turkey from glucose as a fuel into ketones. And that's uncomfortable. It is uncomfortable. Even Dr. Segfried is saying, I don't know if he's made it through a 3-day fast. Maybe he has now. But you'll see this on your CGM, your continual glucose monitor. It's pretty fascinating. You'll see your ketone numbers start to rise. You'll see your GKI, because you get to calculate that. In the Keto Mojo, it calculates it for you, and you can go online and calculate it, or you can do it manual if you want to. But you'll see that your GKI will rise from 10 to 5 to 2 to eventually to 1. So you're in a good place, and it's going to be hard-earned. So those first 3 days will be difficult. Usually sleep is hard for a first day or two, and then it breaks, and you feel okay. It's almost like you could continue fasting for a week or two. That's not necessary. But if we're looking at using the ketogenic diet as a serious cancer therapeutic, then it's a hypocaloric, a low, very low calorie ketogenic diet. What does that mean? That means in the neighborhood of, and it can be calculated on a per person basis, but it's in the neighborhood of 600 calories a day. That's usually about a third of what the average person needs. And in those calories, obviously, is not going to be carbs. It's going to be protein and then fat. Enough protein so you're not breaking down your protein for glucose. And so it's primarily a fat diet. Call it 500 calories of fat, and I'm making it up because you have to tweak it to find out what actual foods are you going to have. But that's how reduced it is. And then you would continue at that level. So obviously you're going to be losing some weight. A normal person would certainly be losing some weight. You will continue for that for, if you could, a week or so. So that's going to be setting yourself up. Other people have, it really depends on how driven you are to change the course of your metabolism. That's pure and simple is what you're after. You're after a metabolic change from glucose as a fuel to ketones as a fuel. And you can do that by starving or fasting, which is really two words of the same thing. Starving is going fasting too long. But some people have fasted for a week or 2 weeks on a water-only fast. They have some coffee in there if they want, but other things that are not going to be calorically of any value. So when you do that, that turning off the glucose pump as much as possible, some immune situations change dramatically. Absolutely. There's stories, there's reports, don't say there's stories, anecdotal, but there are reports, testimonies, if you will, ovarian cancer, various cancers that clear up. Certainly my gut was one of them. My gut wasn't a cancer, but it was highly inflamed, extremely high inflammatory markers. So you can shut that process down. So the question then becomes, first step is getting there. And you can do it softly or you can do it aggressively. That's up to you, but you need to work with somebody while you're doing it. And in my view, you need to have these monitors. That's the CGM, your ketometer, and certainly your weight would help. And ideally, before you got started, you had a whole battery of blood work done that I call a metabolic panel. So we know where you're starting from. And then you continue. And then at some point later on, now you can gradually graduate up to what they call a basal metabolic rate of calories. That is, you're now breaking even, maybe, but it's always good to stay somewhat hypocaloric. If you are so thin that you have no fat to lose, then that's a bit of a question. That's a bit, you obviously can't go very low on your calories at some point. But you get the point. We're going without, you're getting into ketosis, you're creating that metabolic change, and you really are sticking to it. If one is, well, la-di-da, I sort of have, there's different labels of cancer, by the way. I just have stage 1 of naming your cancer, and, well, yeah, I'm sort of bothered, but I'm really not going to spend a lot of attention on it, because if I worry too much about it, it's just going to make it worse. Well, and part of that statement is true, for sure, but not to pay attention. This is really important, to lock this down and to have your data, to track your macros and your food that you're eating, to track your ketones, your glucose or your CGM, and through individual finger pricks, so you can calculate your GKI. If you did that, and of course your weight, if you did that as a bare minimum for a while, that would be helpful information for any physician to see. So now you got how that goes forward. Can't imagine there's any questions on that. So what I do personally, and the tests that I have come to really like to look at, I mean, I the person has to come in, they have to fill out, where they've lived and where they've worked. Had they been an oil field worker for their whole life? Well, then I certainly would expect to a high exposure to petrochemicals, right? Pretty straightforward. Did they have a lot of new rugs in their house in the last 5 or 10 years? Well, they've had a lot of off-gassing of that. That would be, some of those are actually neurotoxins. And so you need to know those things. I used to do a lot of heavy metals chelation until it was pulled from our scope of practice in Connecticut. But so for the better part of 10 or 12 years, we did a lot of heavy metal chelation. And that was technical. We did provoked urine tests to find out what their loads were. And then we would do it intermittently along the way to sort of see how we were doing. That same sort of way of doing intermittent testing is important to find out how we're doing. It's not to overemphasize, oh my gosh, you have cancer, we really need to take care of you. No, but it's need to have some data. Are we doing better? Are you feeling better? And these things need to be followed up on. Again, it obviously depends on the seriousness of the situation with that person and how willing they are to be committed to this particular path of treatment. What I liked about working with cancer patients is that they were very dedicated. By the time they showed up to my door, they listened, they asked questions, they did their homework, and they were type A students all the time. And they got very informed about their particular cancer, so they end up being an oncologist of a sort. But the other labs that I like to do is I do the hormone panel. I think that's very helpful, certainly with women, and men too, but mostly it's with women, and how are they metabolizing their estrogen? That's a big deal. I do like to look at their genome. Do I look at every possible thing? No. There's a couple companies that I use out there. None of them are my favorite. I think they all are really supplement companies in disguise. And so they all have their agenda. But some do a great way of presenting good information. Others make it seem like every mutation you have, SNP, singular nuclear polymorphism, that you have could be the one that makes it worse for you or better for you. Or I think that's too much of a threat hanging over somebody's life. Let's loosen up. But there are clusters, as I've talked about before, there are clusters of SNPs that need to be looked at. They need to be looked at and in light of the situation, in light of your other blood work. So what else do I do? And then I do the intracellular SpectraCell nutrient level. I think that will light up where your nutrient deficiencies are. So if you have egregious nutrient deficiencies that do not just show up in serum, that would be the test I do. So I put those together, and with the big metabolic blood work panel up front. And so that's how I box you in to sort of say, I think I understand this person as well as I understand where they live, where their life was, what I can suspect. I no longer do heavy metal evaluation. I used to, and there was a number of cancer patients that came in high in heavy metal, especially after they started with chemotherapy. With cisplatin is a heavy metal that would come up, and that was secondary to their chemotherapy, meaning caused from the chemotherapy. So that's the kind of degree of seriousness. When people say, oh, Carl or Dr. Goldkamp, could you do a series on cancer and chemo? I'm going to spell it out like this is some serious stuff and you need to be committed. This isn't just, hey, I'm going to drop my carbs and be cancer free in a couple of months. Maybe that would work for you. By the way, I'm not going to say that won't work for you. I can say that for some people, if they are committed to that whole fasting approach up front, maybe fasting for a week or two, and then they start bringing in the food at a very low calorie and very ketogenic way, that's not a bad thing to do. But they need to have some help in the area. They need to sort of do that, not on their own. And there has been some tremendous reports. There are not a lot of studies. I don't think there's really any studies, quote unquote, meaning there's a small population of people that have done this together and this is the results. Those are non-existent from my understanding. Let me go back and give you a little idea of, my brother died of multiple myeloma, and it took about 9 years for that to happen. And that was from pretty much, he died in 2012. And so it's about from 2004 to 2012. It was tough, but to sort of see from onset to gradually getting worse, and people go fast and they go slow. He went slow, which is nice, and but it never ends up well. It's never. He died at 60. He died at about 65, 66 in there someplace. My only brother. But so what did we do then? I knew nothing about the ketogenic diet then. I didn't do. I'm not even quite sure if I knew. Yeah, I did do SpectraCell. He did a lot of SpectraCell tests. We actually did do some heavy metal evaluations on him. We certainly did a lot of blood work. And we were pretty limited to what we could do. He was working, for multiple myeloma, they have to be on medications that, for one, create new red blood cells. It's called Procrit. It's usually erythropoietin, which is similar to what your kidneys kick off to keep your red blood cells in production. But it gets complicated. There's no one thing you can boost because multiple myeloma is the hollowing out of your bones for the most part. And it's the hollowing out of your bones because I don't know if you know this, but in your bone marrow is where your red blood cells are made, and they obviously need to come out of the bones and your red blood cells, right? And into your circulation. Well, with multiple myeloma, you get what they call these punched out lesions, and the exit holes are blocked. And so you end up having anemia, and then you're having a problem with being able to create red blood cells. So it's really the symptoms that people feel most is initially about being tired because they have fewer and fewer red blood cells. And after that, it's about bone pain. And it goes from there, as you can imagine. So what do? We certainly focus on his diet a lot. What would I do differently? Well, there are no studies out there of multiple myeloma and the ketogenic diet, or that's on somebody's fantasy list. So I'd still be on my own saying, hey, here's a great idea, John. You might really want to look at this, and this is how it works. It would be extreme. And no doctor would have said, gee, this is a great idea. Back then they said, no, eat all you want. You need your body needs the new nutrition, quote unquote, is what they would say. It needs the calories and nutrition for your immune system to be able to fight this. And so that would be their carte blanche of a reason to just have patients eat anything. So they would eat wrong things, and they would have high glucose because, heck, they have cancer and they need to eat more to support their immune system. And then it would be just the opposite. So there's a lot of stupidity out there, and nobody's really that interested in going beyond. Remember I went back to the malpractice, the liability insurance that doctors have to have? Well, you're not going to get a doctor who's an oncologist who's specialized in multiple myeloma to consider all these alternative things, because that will come back and be his potential liability. So things don't get better. The standards don't change. Standard of care don't change. New ideas do not come in, and they don't come in because not that the doctors aren't interested. It's just that it's too much risk for them personally and financially, is what they're talking about, to go on and to say, yeah, that's a great idea. Let's do that. So how you have to sell it to your oncologist, who's going to be monitoring you, ideally, Is it, let's watch my numbers, right? Let's watch my blood work. Let's watch and include him in looking at these other labs that we've already talked about. He may or may not be interested, he or she may or may not be interested in any of that, but at least you included them in and saying, let's go, if my numbers get better, let me continue doing this. And that's pretty much the conversation you have to have without becoming ostracized by your doctor. You have to make him a collaborator of your situation and help him care about you, which he does, he or she does. I think I'm just going to start using he for simplicity's sake. So you get that. So again, maybe looking back, it would have been very difficult for me to propose this particular kind of thinking for my brother in that particular situation. There's just not a lot of information on multiple myeloma. They do think it's environmentally induced. There was a spike up in multiple myeloma after 9/11. Those who died in New York City primarily, of all the helpers, by the way, all the helpers being the firefighters and police force and so on that died subsequent to 9/11, not in 9/11. It was from all the burning of the toxins and so on that they had to run through to save people. So that's the structure that I think is really important to listen to. And so even if you're far away and you're picking this podcast up and you're homeschooling, or you're in the Australian outback, or you're homeschooling in Alaska someplace, or far back in Montana, or who knows where, and you go, it's up to me. It's up to me to get healthier. What do I need to do? Well, I would definitely have heard that part about you got to fast for a little bit up front, water fast, so you have some good quality water around. And then it's hypocaloric. And so you can determine, I'm pretending you're that person far away that is not going to be seeing a doctor because it's too far away, though there is obviously online help, right? Telemedicine. That you can line up and monitor yourself in these things. You can't go out and do your own blood work. You can, that's obviously impossible, but you can measure your ketones and your glucose, and you can order for yourself, or at least ask your telemedicine doc for your Freestyle Libre or something more sophisticated like your Dexcom, and start paying attention to that variable. That in itself is a big deal. That's really what the ketogenic diet's about. So if you can start pulling down that little line of a graph in your Freestyle Libre on CGM to have it lower, so it's in the 60s and 70s. When it's into fasting, it will drop. You might even get down to the 40s. I've gotten down to the 40s. People have gotten down even lower. And back in the 60s, there was a lot of fasting, not a lot. There was some really interesting fasting research done by Dr. George Cahill, who worked for the Joslin Institute in Boston. And more things were allowed back then than they are now. And so he had people in the hospital, stayed in the hospital, fasted for 30 days and longer. And in the 30 days, he then even came and gave them insulin, which drops your glucose even further to see what would happen. Well, that wouldn't be allowed anymore because you'd be afraid of death. But actually not much happened. Interesting. So your body adapts, and it can't be forced to have less than it needs, but it can be forced, or it can create the change of you living on ketones. So there you go. So it's something you can do. It is a very big variable. It's a variable that's still not talked about very much. You hear things like, the fasting mimicking diet by Walter Luongo. And that data is strictly on mice, by the way. So as much as it's a neat idea, there is no human evidence of that. He also, which is interesting, he brought up that fasting with chemotherapy was a benefit in the sense that it diminished the side effects of the chemotherapy. And that's a big category because there's different chemotherapeutic agents, and there's different used with different cancers, of course. But nonetheless, the side effects were reduced significantly. The vomiting and the nausea and all that disappeared for many by fasting before getting their chemo. So it's a big variable. You need to scope that out. You need to really take that part seriously. If you're just going to wing it and you're not even going to track your macros, let's say on a chronometer or MyFitnessPal, whatever your thing is, then why bother? Let's take it seriously, get into tracking, learn all the tedium, and then you won't have to do it for a while. But will have to do it. Do you know what 20 carbs or less is? Do you know what 5 carbs is? And if you are allowing yourself to have carbs, don't have it all at once. Like, here's my carb allotment for the day. I'm not going to have a cupcake. That's a stupid way of doing it. First of all, you don't do grains and you don't do starches. If you were to do carbs at all, they would be leafy green vegetables, okay? That's a thing there too. So be smart about how you bring these things in together. So I am going to stop here, and I wanted to set the stage about creating the structure for what one would do to create the best situation in a ketogenic diet where you're trying to address cancer to have you heal as best as possible. So it's creating the structure. I hope you pick that up. I don't want to be so pedantic like I'm, beating you over the head with this, but it has to be put in place. And there are sort of quote unquote rules to do that, and be smart. Track, get the tools you need. And there's more tools now than there were a year ago that I think are really advantageous. The CGM, the Keto Mojo is great. And really calculate these things and keep a tally, keep a spreadsheet on how you're doing. So it's your life. And it's going to be your life in numbers for a while, but not forever. But that's how we get started. So that would be the place about creating the structure. That's the theme of this, creating the structure. Next, I'm going to get back to really get into some of the lab work, and I'm going to go over, for some of it's going to be very interesting. For others, it's going to be very tedious. I don't need to know about this. I just need to know big picture. Well, we're not going to be doing big picture in some of the sequential follow-up podcasts. We're going to get into the labs, and labs that most people do not get from their doctor, and why they should get from their doctor. So they can go, maybe not line by line, but by group, and why I value these numbers. And what I find about the lab work, the intracellular, the hormonal, the metabolic panel, the genomic evaluation. Okay? So we're going to get into some of that, and talk to you then. Bye-bye. Hi, this is Dr. Goldkamp. I just wanted to encourage you to send in your questions to drgoldkamp at ketonaturopath.com. Many of you have, and so what I've done with these questions that gotten back to most of the people I email, but some of the questions that were so good, and if they were overlapping to other questions, I would combine them and try to put that into the topic of a podcast, either via one of the micro topics that are covered in an interview. As you know, we cover a lot of topics in any given interview, or some of my own sort of reporting, if you will, on some of these issues. So please keep the questions coming. Feel free to send in an email, and I will get back to you. One thing I want to say, a number of questions have come in which I've given this answer, and the email didn't work. So just make sure that you're receiving at the same email that you sent it in. And I think that might have been the difficulty. So I look forward to your questions. I just wanted to make sure that you knew that I'm open to answer your questions. And I think this world of keto is not just black and white. It's nice that it's simple, but it's not simple for some. I'm really trying to, go down as any of you who have listened to all my podcasts. We started way back when, history and evolution and epilepsy and so on and so forth. Now we're seeing some tremendous overlap in various mental disorders, such as schizophrenia, or neurological disorders that are not just epilepsy. And also, just for people and losing weight, it's sometimes pretty complicated for them to engage in keto, and so they need some help. And so that's the whole point of, at least that's what I think I'm doing, is exploring the world of why are there other factors. And so in exploring some of those other factors, we've covered addiction, we've covered hormones, we've covered nutritional deficiencies, we've covered certain metabolic lab results, and we'll go further. We'll even get to more on genome and aspects. So these are all just contributions that make for an obstacle for some people to engage easily in the ketogenic diet. This is my belief, and these are the things that I've discovered. And I think other people have discovered some of these things, but not ever put them together. So stay listening, send in your questions, and I will definitely get back to you.